Welcome to another session of microlearning. This topic is going to be on Foley catheter utilization, brought to you by the patient safety coordinators.
Some background on Foley catheter utilization is there is clear evidence that indwelling catheter placement lasting longer than 48 hours is associated with an increased risk of developing a UTI. Catheter-associated UTIs pose negative implications to the patient and healthcare system. Our daily goal is to remove the catheter as soon as critically indicated.
So we're going to focus on the post-Foley removal protocol, which you'll find in your orders. This is your order to remove the Foley based on the catheter algorithm, which you can find under Tools, under Indwelling Catheter Removal Protocol, or you can also find it under your summary page in your Foley catheter bundle.
Start here if an order is present for removal per protocol. Then ask yourself, does the patient have any of the following criteria? Difficulty catheterization requiring urologist placement unless ordered otherwise by provider, post-operative genitourinary/renal invasive procedure/surgery within 24 hours of gynecological surgery, acute urinary retention or obstruction, chronic catheter documented on admission, need for accurate measurements of urinary output in a critically ill patient, significant hematuria, assist healing of open perineal or sacral wounds in incontinent patients or perineal burns, required prolonged immobility with skeletal instability, epidural catheter with bupivacaine, hospice, comfort care, or palliative care. If the answer is yes, reassess the need for indwelling catheter daily or discuss with team. If no, remove indwelling catheter.
If you have removed the Foley, the next step is going to be to assess for adequate bladder emptying. Within the 6 hours post-Foley removal, the patient should void at least 180 mLs. If the patient does, then they have demonstrated adequate bladder emptying, and you're going to promote and maintain normal urinary output, and the protocol will end. If the patient hasn't voided at least 180 mLs in the 6 hours, then you're going to do a bladder scan and measure the post-void residual.
However, if they were not able to void 180 mLs or they have not been incontinent in the last 6 hours, then on the bladder scan is the post-void residual greater than 500 mLs. If the answer is yes, you want to prompt the patient to void, perform intermittent catheterization if they are unable to void, wait 6 hours, and know if the patient void was greater than 180 mLs or if they've been incontinent. Again, if that answer is yes, then the patient demonstrated adequate bladder emptying and the protocol has ended. However, if the patient was not able to void, you waited 6 hours and the patient void was not greater than 180 mLs and they have not been incontinent, then you want to again prompt the patient to void, recheck the post-void residual in 2 hours. If greater than 500 mLs, perform straight catheterization and contact provider for intermittent catheterization orders, and if it's less than 500 mLs, contact the provider for further orders, and the protocol has ended. On the bladder scan, if the post-void residual is not greater than 500 mLs, then you want to prompt the patient to urinate and wait 2 hours to reassess.
If at any point during the protocol the patient is uncomfortable or shows signs and symptoms of urinary retention, bladder scan the patient and notify the provider.
Unlike a static bladder with an indwelling catheter, intermittent catheterization is done on demand and mimics normal bladder dynamics, which reduces the risk of upper urinary tract deterioration, enables a faster return to normal voiding, shortens hospital stay after surgery, and improves the possibility of renal recovery.
When reviewing if the order matches the requirement, practice a questioning attitude. Is the indication for this Foley correct? So you want to verify with the order. Was there a plan to follow up for retention as an outpatient prior to this admission? This is important to verify that you have the correct order. Or is this indwelling catheter still the right choice for this indication?
PCTs are part of the care team and can help by asking clarifying questions like, I'm doing catheter care, do we still need the Foley? Or do you need a chaperone for Foley care?
Now let's implement what you've learned with this case study. We have a 53-year-old male with recent diagnosis of BPH and is admitted to a med-surg floor for GI bleed. The patient has several episodes of urine retention confirmed by bladder scanning, which prompted scheduled straight catheterizations. The short-term rehab facility could not accommodate straight catheterization, so they requested a Foley catheter be placed. The patient returned as a readmission for heart failure with the same catheter. Now 10 days in, and the admission order placed was for critical I's and O's with post-Foley removal protocol.
The nursing staff documented urinary retention for the first day, and then for days 2 to 5 documented chronic as the indication for the Foley. On day 5, the patient requested a voiding trial, and several hours after removal complained of pain and discomfort. A culture was sent and came back positive for a bacterial infection.
Now, thinking about that case study, what are some opportunities for this patient where we could have done better? So regarding this Foley, really getting that history of the Foley and the correct indication is key. Also, we could have considered removing the Foley based on the post-Foley removal protocol, which was there. If you already have a post-Foley removal protocol, that is your order. Also, you want to question if there are meds on board for this retention. We can't just put in a Foley catheter for retention and let the days go by. We have to have some kind of treatment or consult started for this new problem. You also could reach out to the provider to consult urology for this admission. Urology usually sees a patient for retention and has recommendations. And you also can raise a concern if the notes look like they have been just copied and pasted. Sometimes the documentation just looks like it's carried over from the last shift. So you want to kind of question that and say, is this real? Does this Foley catheter really need to be in, or is there an opportunity to remove it and get the patient's bladder functioning back to normal? And lastly, in this case scenario, the order was placed for critical I's and O's, which is appropriate for a medical ICU or surgical ICU, or even the PCU. But if you are in a med-surg unit, this order does not apply to you. There are other ways to measure I's and O's, so that alone is a reason to remove this Foley.
Thank you for taking the time out of your shift to learn about Foley catheter utilization.